Let's start. صباح الخير, good morning everyone, and let's kick it from where did we stop yesterday? You guys remember? I think we stopped at we're here. ولا here crystals ولا here GN crystals. All right. Type crystals, another cause of AKI, post-renal, nephrolithiasis, stones. Don't worry about it. Even attendings get it wrong when we look at the pictures. So we're not going to ask you all these questions. All right. So another etiology of AKI is AIN, right? We said ATN and AIN, that's for the tubular diseases. And mostly caused by two things when we think about interstitial nephritis. If a patient's from Africa, usually, or like from this third world countries, everybody think about infection. And Saudi actually is mostly drugs, except for the northern region, which mostly can happen from infection. And the type of infection that we usually see is not bacterial, viral, but usually either invasive or fungal. So, list of medications, a lot of it. In fact, I can keep going with more slides. But the most important medication that can cause AIN that you should be worried about are NSAIDs, penicillins, Lasix, and thiazide. طبعا, omeprazole is a classic question, but I don't want to ask it because usually it's very rare to happen. NSAID, what other kidney disease can it cause? What kind of GN? What kind of GN? Glomerulonephritis? IgA? Anybody has any other answer? Membranous? Anybody has any other answer? Huh? وشو حلها؟ Membranous or IgA? It's usually either one of these two. Either podocytopathy, minimal change, or membranous. It's a classic question, by the way. All right? Type. Yesterday we talked about how to investigate an AKI. You look at the vitals, right? You look at the physical exam. You check for CBC for the hemoglobin, rule out anemia, or even leukocytosis. You look at the renal profile or the serum, so you can check their creatinine, electrolytes, and acid base. What other investigations are there? In post-renal, everybody check the ultrasound. We don't usually ask it, but if everything is doesn't make sense, we'll check it. Why is it important to assess what? Of course, the size. Why is that important? If the hydronephrosis, if you have obstruction, the kidney will get bigger. We look at the ureters itself as well, right? We can even diagnose and stones in there. Cysts, if it's chronic, there's no acute cysts. There's no such thing as acute cyst in the kidneys. Right? It's chronic. If there's cyst, okay, so we have a chronic problem here, right? Complications and treatment. For the last, I think this is our fifth Mani Ghaltan lecture together. When we talk about kidney disease, we only talk about the same complication, whether it's acute or chronic. What other complications that we usually have? And any kidney disease, you have complications of what? I know it's renal failure. That's why it's kidney disease. Complications, guys. It's a renal failure. Huh? Anemia. Anemia is one. Do we see anemia in AKI? And we're talking AKIs. And chronic, what about acute? So we don't see anemia in acute? ما انت متأكد. Can't be. حبيب مقابل. يجي. طيب. So we're not sure about anemia. طب any other complications? Electrolyte imbalance, like what? Hyperkalemia. Yes, thank you. What else? Acidosis. What else? Uremia. What else? Hypocalcemia. Yes, usually in chronic. What else? In chronic. Or in rhabdomyolysis. So we'll stick with that. But when we talk in general in AKI, what are the 5 indications of dialysis we said? Uremia, hyperkalemia, acidosis, toxins, and hypervolemia. Anemia and acute. Wait, what's the difference between both? Anybody knows? Something like that. What things that can cause azotemia? Pre-renal. No. Pre-renal that cause AKI. Azotemia means asymptomatic elevation in the BUN. Another way to look at it is there's an elevation in the BUN or urea with normal serum creatinine, normal renal function. If it's normal, that means it's not AKI. Like what? Huh?
Someone eating like more food.
So high protein diet like TPN, yes. Catabolic state, not more food, high protein.
Injury.
Injury, what do you mean injury?
There's like injury or something. There's elevated level.
And burn patient, for example, usually they're associated with AKIs. What else?
Isn't the symptoms in nephrotic syndrome?
Huh?
Is the symptoms in nephrotic syndrome?
What do you mean, معلش?
Nephrotic syndrome disease. They sometimes
Nephrotic syndrome,
yeah.
أيوة.
Nephrotic.
And nephritic, أيوة.
They have azotemia.
In nephritic, they have AKIs. So when I mean azotemia, I mean there's high BUN or urea with normal renal function. Nephritic is abnormal renal function. Does that make sense? Huh? What? Nope. Nope. You guys did not take GI, correct? GI bleed. It's notorious to cause an elevation in the urea. Why? I'll leave that to your GI block or whatever. Steroids, high dose steroids. I said catabolic state. So these are the major three things: high diet, protein diet, or TPN, corticosteroids, and GI bleed. So we'll focus on these two. You already talked about hyperkalemia. Will make your life easier. These are the differences that you guys mentioned already: azotemia, elevation in the BUN with no symptoms, like GI bleed, TPN, and corticosteroids. Why is that important? Because there's a difference between symptoms, and it's all over the place. It can go from chest pain, encephalopathy or seizure, to nausea and vomiting. So you have to be very careful, because when we get a call and somebody said, "Hey, Khalid, I think this patient is uremic," like, you can't say that, because if you say that, legally I have to dialyze them. Are you sure they're uremic? It's one hell of an experience that nobody wants to go through if you have to put them on dialysis, right? Or they come with pruritus. We see it a lot in the clinic. You go, I can't stop itching. I can't stop itching. And the treatment is not actually antihistamine. We actually give them a nerve blocks or blockades, like Neuront and stuff like that. It's pretty bad. And there's other signs. Pericardial effusion or asterixis. Do you know what asterixis is? Flapping. We usually see it in cirrhotic patient with hyperbilirubinemia or severe uremic patient. Basically, we tell the patient, try to be like a police officer, try to stop the traffic, keep your hands like this. A few seconds, they'll do flapping. Because this is the treatment, gentlemen. Blood comes out, goes to the machine, cleans it, goes back in with all its complications. And this is the filter where the magic usually happens. Hyperkalemia, we talked about it. صح? Do we have to go through it again? These are the medications. Already talked about the AKGs, correct? How would you manage it? How would you manage hyperkalemia? Okay, so one of your colleagues wants to give albuterol. Why do you want to give albuterol? Intracellular shifting, absolutely. What else? Insulin, yes. Why? It also causes intracellular shift. When you give insulin, you give, along with it, glucose, D50, yes. What else? Why do you want to give calcium? Because what? Shifting. No. It does not cause shifting.
There's a medication that shifts potassium with calcium and then takes it out.
What?
Can we give antagonist?
What do you mean antagonist?
To prevent sodium when we have the aldosterone that take the...
You're talking about the hydrogen potassium channel in the alpha intercalated cells, in the collecting ducts, right?
Block the function of aldosterone.
Aldosterone.
So it does not excrete potassium.
But you want to secrete potassium.
Fiber.
Hey, hyper. If you give spironolactone, which is an aldactone inhibitor, will make it worse. No, it's not. No, that's a good thought. You thought about maybe make that channel work harder. but we don't have a medication for it. But another way, yes, you will give calcium, but not for shifting. Why do we give calcium? Means that. Yes, we need to increase the threshold of the membrane of the myocardial cells to avoid arrhythmias. What else? This is for the treatments. We're managing now. There's a difference between managing, that means you're trying to stabilize. Treat is trying to get rid of the potassium from inside the body. Huh? That's when in treatment. We're still in management. What else? I need 3 more. I told you you're going to be doing it all at the same time. How about bicarb? Yes, thank you, يا أخي من أول. EKG. You have hyperkalemia and you don't want to get an EKG and the complication is arrhythmia? That's a lawsuit. EKG. Repeat the labs to rule out pseudo hyperkalemia. Right? To confirm it. And the lastly is bicarb. So give sodium bicarb for also intracellular shifting, because acidosis will make it worse. You'll do all at the same time. Okay? Don't worry about the units or the doses. How would you treat? Diuretics is one. Yes, you're going to force the kidney to secrete potassium. Loop diuretics works in the ascending loop of Henle. While also secrete potassium, also will cause sodium delivery to the collecting duct and the distal tubule, which will activate the wrong channel, which will secrete more potassium. Yes, good job. Somebody said something about GI tract, right? You want to give potassium binders, whether it's Lokelma, K-Exalate, or what do you call it? Pateromir. Or lastly is? Yes, dialysis. خلصنا. We're done. بس. Any questions? Yes, you do.
Based on your experience, you just talked that if you do dialysis for 3 to 5 or for a long time, you will develop cyst in the kidney.
No, they will not develop cyst. They will develop cancer. RCCs. The kidney usually with dialysis because it's not working. If you don't use anything, لحظة يا شباب، معلش حمشي بعد شوي. بس لحظة اصبروا علي. بعدين خلاص خذوا وقتكم. When you don't use anything, hey, لحظة شوي. أنا حمشي بعد شوي. خلوني أجاوب السؤال. When you don't use anything, what happens? Atrophies. Anything will atrophy. So our muscles will get smaller. So the kidney will get shrunk. It will get small inside. And when it gets smaller, because there's nothing going on, also, then it becomes what? If it's not functional, it becomes almost, think about it this way, that will make it easier to remember, like a foreign body. If it's a foreign body, what's the body trying to do? Try to attack it, try to get rid of it, and then it becomes cancerous. So any cyst, it's common to see cysts. But if we see cysts, usually, in dialysis patients, with maybe hypertension, with maybe an improvement in the hemoglobin, we have to remove it. 20 to 30% of all cysts in dialysis patients are cancer, renal cell carcinoma. So that's why we remove it. Okay? But that's not a question you will get into. You took it in path. Okay. Abrar? I hate basic. They ask irrelevant questions. Fact, 50% of what you learn in medical school is not true. We don't use it in practice. I always had a problem with the Krebs cycle. Any question? The ladies had questions about the electrolytes and the acid base. We did more questions about the acid base. You guys are good with it? Khalas, you're comfortable? GN, you're comfortable? Good luck.